Uh, Hi, everyone. Welcome back to this live session on the professional exams made easy, where we are discussing important topics related to your university exam. In the last session, that is on Monday, we had discussed about the important short essays and long essays asked from the interior of the GI organs as well as the urinary organs. Today, we will focus on two important questions which can come from the anterior abdominal wall and the inguinal region. One is inguinal canal and the other one is the rectus sheath. Inguinal canal is a potential 10 marker question, whereas rectus sheath is a 5 marker, and some of the universities have even asked as a 10 marker question, right? So if these two questions are asked, let it be a case-based question, let it be a direct question, how to answer, let's try to understand. What we'll do is, first, we'll try to start with the inguinal canal, and then we will focus on the rectus sheath answer, right? Now, this session provides you the actual guidance on how to present your answer if these two questions are asked, right? So first, let's start with the inguinal canal. Now, if inguinal canal is asked, how do we answer this topic? First, we start with the definition, right? So what exactly is inguinal canal? So inguinal canal is an oblique intermuscular passage, right? It is an oblique intermuscular passage. Where exactly it is situated? Remember, it's an oblique intermuscular passage situated in lower part of anterior abdominal wall, in the lower part of the anterior abdominal wall, just above the medial half of inguinal ligament, right? Medial half of inguinal ligament. This is the complete answer for the definition of inguinal canal. This is what the examiner actually looks for. So what does you need to highlight? What do you need to highlight? So one is it's an intermuscular passage where it is located in the anterior part of the lower part of the anterior abdominal wall above the medial half of inguinal ligament. So just highlight it, right? Then what about the extent? Remember, the extent is from the superficial inguinal ring, right? The superficial inguinal ring to the deep inguinal ring, right? The entire length of the inguinal canal is about 4 centimeters and it extends between these two landmarks, the deep inguinal ring to the superficial inguinal ring. As we will discuss, one of this will become the inlet and one of this will become the outlet of the inguinal canal, right? Now, the most important thing about the inguinal canal is with respect to its boundaries. How do we define the boundaries of the inguinal canal? Right. Remember, inguinal canal has an inlet, an outlet, an anterior wall, a posterior wall, a roof, and a floor. Right. So these are the 6 walls of the inguinal canal. First, let's start with the inlet. Now, what structure is called as the inlet? Remember, the inlet is the deep inguinal ring. Now, what exactly is the deep inguinal ring? Remember, deep inguinal ring is a defect in the fascia transversalis, right? It's a defect in fascia transversalis. Where is it located? Remember, it is located about 1 to 1.25 centimeters above the mid inguinal point, right? So when you write inlet, 3 bullet points. What is the inlet? Inlet is the deep inguinal ring. Then what is it? It's a defect in the fascia transversalis. Where exactly it is located? Third point. So 3 points for inlet. This should be enough. Very often we have seen students actually, when it's asked about the boundaries, they tend to forget about the inlet and the outlet. So these are the 2 things that we must highlight, right? The inlet and the outlet. Okay. Then what about the outlet? Remember, the outlet is formed by the superficial inguinal ring. Okay. It is formed by the superficial inguinal ring. First point. What is superficial inguinal ring? Remember, it is a triangular defect, right? It's a triangular defect, or we can say it's a triangular opening or a triangular slit in the external oblique aponeurosis. Second point, right? So similar to the deep inguinal ring, we must write where exactly the outlet is located. Then the next thing is where exactly it is located in the external oblique aponeurosis, right? So it is located above and lateral to the pubic tubercle, right? So it is located above and lateral to pubic tubercle. This is what we need to write for the outlet, right? Now, do we need to write a diagram for this? If allowed, or if you have time, you can write one simple diagram for this extent of the inguinal canal. So let's imagine this is the inguinal ligament. So this is the inguinal ligament, right? So this is the outline of the inguinal ligament. Here we have the pubic symphysis and the pubic tubercle, right? So inguinal canal can be shown as an oblique intermuscular passage extending between the superficial and the deep inguinal ring. This simple diagram itself is enough. Okay. Show the costal margin to show that, like we are showing the anterior abdominal wall. This simple diagram itself is enough to show the extent of the inguinal canal, also the inlet and the outlet. Just label it. Right? Are we clear? Now, once we have written about the inlet and the outlet, the next thing is to write about the rest of the boundaries. Okay, the rest of the boundaries are formed by the four walls: an anterior wall, a posterior wall, a roof, and a floor. Right. So what we will write for each of these walls? First, let's start with the anterior wall. Remember, the anterior wall, you can actually begin with the skin, right? Before we get to the anterior wall, these are the structures we have, right? So one is skin, then we have the superficial fascia. Of course, we have two layers. Then we have the external oblique aponeurosis and internal oblique aponeurosis, right? Internal oblique aponeurosis especially is located in its lateral 1/3. So these are the four structures that form the anterior wall. Again, write one below the other so it adds to the volume of your answer. Your answer looks big. Some of the examiners actually look for whether you have written like more content, right? One of the way to make your content look bigger and voluminous is write the points one below the other. So this is regarding the anterior wall. Then what about the posterior wall? The posterior wall, remember, again, try to list one below the other, right? Now, the first structure we will write as the fascia transversalis. Okay. So fascia transversalis will form the posterior wall in the entire extent of the inguinal canal, the entire 4 centimeters, right? But the most important structure here would be the conjoint tendon. And the examiner would expect you to mention that this forms the posterior wall only in the medial half. So the posterior wall is strengthened in its medial half by conjoint tendon. Now, what is conjoint tendon? Conjoint tendon is the combined insertion of the transverse abdominis and the internal oblique, right? This needs to be written and this needs to be highlighted. Done. Apart from this, we also have one more important structure, which is the reflected part of the inguinal ligament. So one of the part of the inguinal ligament which forms the third structure forming the posterior wall of the inguinal canal, right? Then what about the roof? What structure actually forms the roof of the inguinal canal? Remember, the roof of the inguinal canal is formed by the arched fibers of the internal oblique muscle, right? So arched fibers, right? Arched fibers of the internal oblique. Apart from internal oblique, we also have the transversus abdominis muscle, right? At this point, one thing that we need to highlight, the internal oblique forms the anterior wall, it forms the roof, it also forms the posterior wall. Why is this important? Remember, once you have written about the roof, in one line, add a point stating that the triple relation, right? Triple relation of internal oblique, where you will write internal oblique forms the roof plus anterior wall plus posterior wall, right? Highlight it so that this catches the attention of the examiner, right? So even if you have made minor mistakes in rest of the boundaries, that is overlooked, right? So this triple relation you need to mention. Then the last thing is regarding the floor. As we know, the floor is formed by the medial half of the inguinal ligament. Done? So this is how we write it. Now the big question, what diagram to draw for inguinal canal? The diagram of the inguinal canal looks very tough, right? So how do we draw it? Now remember, you don't have to worry too much about the diagram here. First, write the floor of the inguinal canal. Okay, right? So this floor of the inguinal canal is formed by what structure? This is the inguinal ligament, right? So just for the purpose of understanding, this is above, this is below, this is anterior, this is posterior, right? So write the grooved upper surface of the inguinal ligament which forms the floor. Then the posterior surface is formed by a structure. What is it? This is the fascia transversalis, right? What is the anterior wall formed by? The anterior wall is formed by a muscle. Now, what muscle will you write here? Okay, what is the first muscle that we have? The first muscle that we have is the external oblique. The external oblique aponeurosis will continue downward as the inguinal ligament. So remember, inguinal ligament is a modification of the external oblique aponeurosis. Then behind external oblique, what do we have? The external oblique posteriorly we contain or we have the internal oblique, which forms the roof, as well as we have the transversus abdominis muscle. And you can even write the content of the inguinal canal, which is the spermatic cord with the vas deferens. Then we have the testicular artery, the pampiniform plexus of veins. We also have the nerves and lymphatics, right? So this is how we can, in one simple diagram, mention about what? The boundaries of the inguinal canal, right? As seen in the sagittal section. If we pass a sagittal plane through the inguinal canal, this is how the boundaries will look. So even this diagram is enough to show the boundaries of inguinal canal, but mention it as the sagittal section, right? Are we clear? This is regarding the boundaries of the inguinal canal. Done? Now, once this is done, the next thing is to write about the contents. Now, what do we do in mentioning the contents of the inguinal canal? In contents, first divide it as males and females, right? Further, divide the content in males and females as complete and incomplete content. For example, in males, what is the complete content of the inguinal canal? The complete content of the inguinal canal is the spermatic cord, right? What about incomplete content? Remember, the incomplete content is the ilioinguinal nerve. Ilioinguinal nerve enters the inguinal canal by passing through the posterior wall, that is fascia transversalis, then traverses through the inguinal canal before it comes out of the superficial inguinal ring. That is why we call it as incomplete content. In case of females, the complete content becomes the round ligament of the uterus, right? Round ligament of the uterus. and incomplete content again becomes the ilioinguinal nerve. Are we clear? So this is how we write the contents of the inguinal canal. Males, females, complete, incomplete. Now the question is whether we should explain the spermatic cord in detail or not. My suggestion, if the question is a long essay, then talk about spermatic cord in detail, right? How do you describe? First, talk about definition. What is spermatic cord? It is a cord-like structure that passes through the inguinal canal and suspends the testes, right? It contains the structure which traverses to and fro from the testes. Definition. Then the next thing is with respect to coverings. We know that the spermatic cord has three coverings, three intrinsic coverings. The external spermatic fascia, then we have the cremasteric fascia, and then we have the internal spermatic fascia, right? So three fascias: external spermatic fascia, then cremasteric fascia, then internal spermatic fascia. So three fascias in order. Then talk about the contents, right? What are the contents present in the spermatic cord? Remember, the most important content present in the spermatic cord is the vas deferens, right? Once you write vas deferens, you can write every other structure, but this is a must, right? You cannot forget vas deferens. So once you write vas deferens, next you can list the testicular artery. Then you can list about the pampiniform plexus, right? The pampiniform plexus of veins, right? Apart from this, we can talk about lymphatics and other nerves present in the spermatic cord. Are we clear? So one more important structure that most of us would miss is the genital branch of genitofemoral nerve. Then we can add lymphatics, and one more structure most of us forget is remnants of processus vaginalis. Right. So these are the structure we can mention as the contents of the spermatic cord. Remember, the spermatic cord itself, this itself is an important short note, right? But if inguinal canal is asked as a 10 marker question, it's always better to talk about spermatic cord in detail. Are we clear? Right. Now this is regarding how do we describe inguinal canal. The answer of inguinal canal is always incomplete without the defense mechanism that prevent the occurrence of inguinal canal. So how do we write it? So first list the mechanisms, right? And in front of each mechanism, add one or two lines what exactly it is. For example, what do we mean by shutter valve mechanism? It is like pulling the shutter down, right? So what happens here? Remember here, the roof and the floor approximate, right? So when roof and floor approximate, the inguinal canal closes, right? So there is no chance of any content coming out of it. So this is roof and floor. Then what do we mean by ball valve? Ball valve mechanism, remember, is associated with a reflex called as cremasteric reflex, right? So what happens here, whenever we stroke the skin on the medial side of the upper and medial aspect of the thigh, the spermatic cord, it is pulled upwards. The testis is pulled upwards by the contraction of the cremaster muscle. The afferent limb is formed by the femoral branch of genitofemoral nerve. The efferent nerve is formed by the genital branch of genitofemoral nerve, which actually supplies the cremasteric muscle. So when the spermatic cord pulls the testis up, the testis blocks the outlet or the superficial inguinal ring. This actually prevents the occurrence of the inguinal hernia. Are we clear? So this is regarding the valve mechanism. What do we mean by the slit valve mechanism? In slit valve mechanism, what happens? Remember, in slit valve mechanism, the crura of superficial inguinal ring, right? crura of superficial inguinal ring, these approximate, right? So the two crura, it's a triangular opening and these triangular opening close. What about flap valve, right? Flap valve is when the anterior and posterior wall approximate because of the obliquity of the canal, right? Are we clear? So apart from this, what are the other mechanisms we need to write? Then in case of guarding mechanism, what do we write for the guarding mechanism? Remember, in guarding mechanism, what we need to mention is the deep inguinal ring is guarded by the internal oblique muscle, right? So what is deep inguinal ring? It is an opening or defect in fascia transversalis, right? Now this is strengthened by the internal oblique. So this we can mention as the guarding mechanism. Then what do we write? Remember, posteriorly, the guarding is done by the conjoint tendon. So this we can mention for the guarding mechanism. So mentioning these 5 mechanisms for the defense mechanism of inguinal canal is a must. This itself could be a 3-marker or a 5-marker question. Then how do we end the answer of inguinal canal? We end the answer of inguinal canal by talking about the inguinal hernia. Now, what is inguinal hernia? Remember, it is the protrusion of the contents of abdominal cavity right through the inguinal canal. So this is what we call as hernia. Hernia is basically protrusion of any content through the wall which contains it, right? So here inguinal canal forms an inherent weak point in the anterior abdominal wall through which the abdominal contents can come out. This is divided into direct and indirect type. Now, what do we mean by direct type? Remember, when the hernia enters inguinal canal, right, through the posterior wall. We call it as direct inguinal hernia. When the hernia enters inguinal canal, right, inguinal canal through the deep inguinal ring, traverses the entire extent of the deep inguinal ring and the inguinal canal, comes out of the superficial inguinal ring, we refer it to as the indirect inguinal hernia. The direct inguinal hernia is very common in old age, whereas the indirect inguinal hernia is more common in young adults, right, and even in children. One of the most important differences when it comes to covering, right? Remember, the direct inguinal hernia will always have a covering of fascia transversalis because this forms the posterior wall. Whereas this fascia transversalis is absent from the covering of the indirect inguinal hernial sac. Could be an important MCQ. But if inguinal canal is asked, this is how we will write the answer for a 10-marker question. So don't worry too much about drawing too many diagrams. One diagram to show the extent and one diagram to show the boundaries. And if needed, right, in simple, you can show the spermatic cord. Let's imagine this is the internal spermatic fascia. This is the cremasteric fascia which is covering it. And then we have one more fascia, that is the external spermatic fascia on the outside. And then write the vas deferens as the most important content, then the testicular artery, then we have the pampiniform plexus of veins, then we have the nerve, right? What nerve? So let's imagine the genital branch of genitofemoral nerve. We have the lymphatics, right? And we also have what? The remnants of processus vaginalis. So this diagram to show the spermatic cord and its contents, this is enough. Are we clear? So this is how we will write the anatomy of the inguinal canal if it's asked as a 10-marker question. Hope it is clear. Now, let's discuss one more important question, that is rectus sheath. If rectus sheath is asked, how do we represent the answer for the rectus sheath? Let's try to find out. Okay, so rectus sheath could be a 5 marker. Very rarely it has also been asked as a 10 marker question. This is how we phrase the answer. Define what it is, describe how is it formed, and when we discuss about formation, above the costal margin, between the costal margin and the arcuate line, below the arcuate line. So 3 levels we need to mention. Diagram we will write. Then the contents, the clinical anatomy. As simple as that. Okay. First, let's start with definition. What is the definition of rectus sheath? Remember, rectus sheath is an aponeurotic sheath, right? It is an aponeurotic sheath covering two muscles. What are they? One is the rectus abdominis muscle, and the other small muscle it covers is the pyramidalis. So it is a tough aponeurotic sheath which covers the rectus abdominis and the pyramidalis muscle. Are we clear? Then, how is it formed? The formation of the rectus sheath differs at different levels, right? There are 3 levels that are defined. One is above the costal margin, then between the costal margin and the arcuate line. The third level is below the arcuate line, right? So, how is it formed? At each level, there is anterior wall and posterior wall. So let's try to understand the formation. The anterior wall above the costal margin is formed by the external oblique aponeurosis, right? Then posterior wall. The posterior wall is deficient here. Here, the muscle lies directly on the 5th, 6th, and 7th costal cartilages. Right? Now, how do we show this? Show the rectus abdominis muscle of one side. Okay? So let's imagine this is the rectus abdominis muscle of one side. How exactly the anterior wall is formed? So anterior wall, let's imagine we have what? We have 3 muscles here. So one is the external oblique, then we have the internal oblique, and then we have the transversus abdominis, right? The external oblique forms an aponeurosis, right? Now this aponeurosis covers the anterior surface of the rectus sheath and gets inserted into the linea alba, right? So this is how the anterior wall is formed. The posterior wall, it rests directly on the costal cartilages and the ribs. This is how the rectus sheath is formed above the costal margins. Then, between the costal margin and the arcuate line, how is it formed? So, anterior wall is formed by the external oblique aponeurosis plus internal oblique aponeurosis. These two aponeuroses fuse to form the anterior wall. How? We will see. What about posterior wall? Remember, the posterior wall is formed by the internal oblique aponeurosis plus transversus abdominis aponeurosis. How? We will try to understand. So what we'll do is, we will write this diagram again. So this is the rectus abdominis muscle. This is the external oblique. Here we have the internal oblique, and here we have the transversus abdominis, right? So what happens to the external oblique? The external oblique covers the rectus abdominis and gets attached to linea alba. The internal oblique aponeurosis splits into 2 lamina. The anterior lamina will fuse with the external oblique aponeurosis to get further inserted to the linea alba. The posterior lamina gets inserted to linea alba. The transversus abdominis gets inserted to this posterior lamina. All of them will get inserted into linea alba ultimately. This is how the posterior wall and anterior walls are formed between the costal margin and the arcuate line, right? Then below the arcuate line, how is it formed? Remember, below the arcuate line, it is formed by aponeurosis of the external oblique, internal oblique, as well as transversus abdominis. Right? How about posterior wall? Posterior wall is formed by fascia transversalis. Let's try to understand the formation now. So again, we have the rectus abdominis muscle. Let's imagine here we have the linea alba. Here again we have the external oblique, the internal oblique, and what do we have here? The transversus abdominis muscle. The aponeurosis of the external oblique receives the aponeurosis of the internal oblique and also the aponeurosis of the transversus abdominis, all of which get inserted to the linea alba. The posterior wall is formed by the fascia transversalis, below which we have the extraperitoneal fat, right? Extraperitoneal fat, and we have the parietal peritoneum. So this is how the rectus sheath is formed below the level of the arcuate line. Are we clear? This is how we should write 3 diagrams for the 3 attachments. Better way is just in front of the attachments, mention, or just in front of the formation, mention this diagram, draw this diagram. This will help the examiner to evaluate your answer very quickly. Are we clear? Right. Once we have written it, then let's talk about the contents. Now, in the contents, we need to list and then we need to mention what are the structures present. For example, the contents can be listed as 2 muscles, 2 arteries, 2 veins, 6 nerves. Right. So what are the 2 muscles? So muscles we are aware of. What are the muscles we have? We have the rectus abdominis muscle. Right. Then we have the pyramidalis. So these are the 2 muscles present within the rectus sheath. Then what about 2 arteries? We have the superior epigastric artery plus inferior epigastric artery. What about veins? The superior epigastric vein plus the inferior epigastric vein. Then what about 6 nerves? The lower 6 thoracic nerves. The last 5 intercostal nerves and subcostal nerve. You can even write like this. Okay, this is regarding the contents. Then, what about clinical anatomy? Why we should know it? The divarication of recti. What do we mean by divarication of recti? Divarication of recti means there is separation of the 2 rectus abdominis muscle by splitting of the linea alba. Right? This could be one of the important clinical anatomy. Second, the occurrence of epigastric hernia through the linea alba. Right? These 2 can be mentioned as the clinical anatomy points. Are we clear? What we did now, in 8 to 10 minutes, we tried to describe rectus sheath. This is what you need to write for your exam. The long essay, inguinal canal, we tried to write it down, let's say within 25 minutes. As we have discussed again and again, if it's a long essay, do not spend more than 25 to 30 minutes. If it's a short essay, do not use more than 8 to 10 minutes to answer. Right? So this is regarding the 2 topics that I wanted to discuss today. Right? Coming week, that is next Monday, we will take up few more important topics. And what we'll do on Monday is we'll try to discuss about the important short essays from embryology. In embryology, there are limited topics which are asked, especially in general embryology. So what we'll do is we will focus on the topics of general embryology because this is where we find much more difficulty in phrasing the answers, in framing the answers. Fine. So by next Monday, we will discuss general embryology, and possibly next Thursday, we will focus on the systemic embryology topics. If these are asked, how to present the answer. Are we clear? I once again thank all of you for joining this session. See you all next week for the session on general embryology. Thank you.